know, this talk is kind of aimed at a wide variety of audiences. For many of you, this may be, some of this may feel old hat and like things that you really feel familiar with. And then I hopefully at the end, some of the things that I'm talking about might be a little bit new or things that will be coming down the pike in terms of home-based care. Like I said, please feel free to, I can't see everybody here on the screen. So if you have questions, just go ahead and unmute yourself and ask, or put it into the chat, which I can see easily. Would love to hear for your perspective, or if you have anything to share from your own experiences, definitely feel free to share. So as Dr. Reinhardt said, I'm a home-based primary care provider here at Mount Sinai. I've been doing this for 5 years on faculty, and then had a panel of patients as a fellow and as a resident as well. And obviously, you know, home-based care is something that I feel really passionate about. I think it's a really unique opportunity to be able to see our patients in their home setting, obviously, and really get to know them on a deeper level in a way that really contributes to their care. I also think it's really important for people, you know, I recognize that I do a lot of talks to people who are not going to eventually be in home-based care, right? Not everybody, there aren't enough providers to go around as it is. And so we really need to be making the use of the time that we have. I think it's really important for all of us as providers, whether you're a specialist, primary care, to really be able to understand what is out there and how to be able to access it and how it's going to contribute to the care that you provide in a clinic setting or in the hospital. So we have a few learning objectives, which is really just to understand what it means to be homebound, understand the elements of a home safety evaluation, think about how somebody's homebound status might affect the kind of care that they receive, and then reflect on the role and significance of both paid and unpaid caregivers involved in the care of a homebound person. So I'm wondering if you could all just think about the most complex patient you've seen in clinic or in the hospital. And this could be complex medically or psychosocially. And then would love to hear from you all. If you can, if you're able to, go to slido.sli.do and then just type in #home visits. And there should be a question there. And that question is, so if you could do a home visit for that complicated person that you maybe just can't quite, you know, quite figure out what is going on, there's something that's missing. So what would be the most helpful thing for you to see or know?
So you have some folks in the chat.
Oh, okay, that's fine.
Yeah,
that's fine. Yeah, absolutely. Okay, so safety in the home, family involvement. Some people wrote cleanliness, kitchen. Family environment. What matters most. Great, I like that because it's sort of pointing to the sort of familiarity or putting the patient in a place that's comfortable to be able to assess those harder questions. Condition of the home. Great, so I think I agree. I mean, I think these are all, you know, the things that are really helpful to be able to see with your own eyes, right? A lot of these things are things that you might not be able to ask about, or if you were to, I don't know, you know, for some of these questions, you know, asking somebody what's in their kitchen is probably just not going to be the same as opening up their fridge and seeing what they've got there. And we know, so what, you know, what are the reasons that we like to visit people at home? And it's because of those social determinants of health, right? All the different drivers of health that may not be strictly medical, but actually influence care. Like people said, the environment, both inside and outside the home, their support system, the family environment, a bunch of people referenced that, and then health maintenance. So, you know, the other thing you can understand, right? What are the barriers to somebody being able to access certain parts of their preventive care maintenance when they can or cannot get out of their home? So it helps you put things in, helps you sort of prioritize the different things that you need to do for a patient. So, we really think of these as kind of an invisible population. There was some work done by a colleague of mine, Catherine Ornstein, here at Mount Sinai, and it was the first time they'd really looked to see how many people are considered homebound. And so when they were looking at this, they said 1.9 million US adults over 65 are completely or mostly homebound. And this was defined as completely homebound was didn't leave home in the last month, and mostly homebound was left home less than once in the last 2 weeks. And then for comparison, there are 1.4 million people in nursing homes, and this was in 2012, which was sort of contemporary to the paper. And I think this was just really eye-opening for us to recognize the volume of people who are at home who really need to be able to access care. And in a lot of ways, the nursing home population is one that is much more sort of visible or salient that come to mind. And then strikingly, only 12% of the completely homebound reported receiving primary care services at home. And so we know that there's a big need. And, that doesn't mean that those other 88% were not receiving any primary care. Probably some of them were able to get out to a clinic and able to access some primary care. But we do know, anecdotally from the patients that I pick up in when I'm doing a first-time home visit, some of them haven't seen a provider in 5 years or more. Either they're not on any meds or they stopped taking them because somebody wouldn't prescribe them without having seen them. So there is a really big need. So to qualify for homebound services is not actually that hard. It requires meeting the Medicare definition. Many of your geriatric clinic patients would meet this definition, right? So all it means is that it's hard to get out. So either you need the help of somebody, or you need the help of a device, or you need some kind of special transportation, and that leaving home makes you feel worse, right? It causes more pain. It makes you feel more short of breath. It makes you feel tired. And so that bar is pretty low actually for a lot of our older patients. And then the second piece is that they need to only leave home infrequently and for short duration. And so it's written in there that they can actually go to other doctor's appointments, dialysis, to senior day health. They can go to church or the hairdresser, but they're not people who are kind of out and about socializing on a daily basis, right? And we all know patients who may have tremendous disability, but still manage to get out and still want to get out, versus those folks who really are not accessing things because it is so much harder for them to get out and about. Okay. So for home safety assessment, there's a lot of different ways that you could do this. I think I personally like to keep things simple, and so I've sort of broken it out into these 4 categories. I think depending on your workflow, sometimes it makes sense to have a long checklist, right? If you have a lot of different providers who are maybe working in a team to take care of somebody, then you might want to have something that's a little bit more standardized, where you could send anybody out into the home, whether that's a student or a provider or a social worker, really anybody, to go and ask a long list of questions and check things off. Our program is a little bit different. I think just the way that we work, each of us kind of does it our own way, and then we work together with our IDT to ensure that we're kind of covering all our bases. But I think about it in 4 broad categories. The first one would be that environment, which is sort of the overall, right? Is it clean, tidy? Does it feel safe? And that includes, like we said, both outside of the building, right? Your apartment itself might be quite nice and feel safe, but if you feel nervous getting out of your elevator and leaving, then that's an important thing to know. Is there good lighting? Do they have pets? How easy is it to enter or exit the building? And you all living in New York really know that there are a lot of buildings, old buildings, that are just not set up for somebody with a gait impairment or with a wheelchair. And the number of elevator buildings that still have 4 steps to get to the elevator is sort of astonishing. And that, just even 1 step can be a huge barrier for that person in a wheelchair. Second, medication. So how do they keep track? Where do they store their old medications? This is an actual picture of one of my patients countertops in their kitchen, which is just jumbled with, right, there were antibiotics from years ago, vitamins, nutritional supplements, just all in a huge jumble, which is not something that I think anybody would ever have revealed to me in a in an interview. Thirdly, a kitchen. So many of you mentioned this, but so is there fresh food, adequate groceries? For somebody who has heart failure, right? It gives you an opportunity to actually open up the cabinet and see what are the things that they're eating and how are they affecting this person's medical conditions. Or is it empty, you know? Or do you see that they have been getting Meals on Wheels but don't eat them? There's a lot of things that you can really gain about their social situation and medical situation from having access to that room. And then finally, the bathroom. So what kind of equipment do they need to toilet and shower? And this is kind of just a general DME survey, right? So walking around, and I always ask permission to do this on the first visit, and I often will do it again later on. Can I just walk through and see how it is that you're getting through your own spaces, right? Are there grab bars in the shower to make it easy to get in and out? I think also sometimes seeing all that kind of equipment, if somebody has a hospital bed already or has a commode, is an indicator that they've been somewhat plugged into care, right? Someone has been there before you and been able to provide some of these assistive devices that somebody might need to be safe at home. The other thing that you can learn is, do they have a commode and 3 canes and a walker, but they're all piled in the corner and they're not using them? So, right, so you can better understand your patient as you're gathering all this information. And I find that kind of having these categories in my head as I'm going through my initial visit can be really helpful, because that first visit can be really overwhelming, right? There's a lot. This is, I think there's when you're in a clinic setting, a patient can come in that's quite complicated, but it's sort of on your own turf, right? You've kept the surroundings constant and there aren't distractions. And I think when you're in somebody's home setting, there can be a lot of things that are pulling you in different directions. And so even if it means saying, wow, I'm going to put off this home safety assessment, I'm going to, do the big picture things right now, but I know I need to see this person in a couple of weeks just to really complete my assessment because it is that overwhelming. You always have the opportunity to do that. So I just wanted to introduce a case. So a patient of mine, Ms. M. So she has COPD and hypertension and OA, and this is based on somebody I had in geriatrics clinic. So she missed several appointments because she was short of breath and had fatigue. And she's coming in alone today, and you find out that she's had a couple of falls since her last visit 5 months ago. Her vital signs are pretty unremarkable. And on exam, she's frail, but she's in a good mood, but it took her a long time to walk to the exam room. She's having some pain, she's wheezing a bit, but no edema. And you're probing a little bit and asking her about how she takes her medications. And she just says, oh, I take them the way I always have. I take my pills every day, but it's pretty cagey. So what else do you need to know? What else are you worried about? You can go ahead and type into the chat.
Cyan, did we give people the ability to unmute? Okay.
Yes.
So we did, even though we're in webinar form, everybody, you can unmute if you'd prefer.
Anything anybody's worried about?
Not taking our medication properly.
Yeah.
Even though she said that she has, but you never know.
Right. So it could be a question of education. It could be a question like maybe nobody's ever counseled her. Maybe she's got some cognitive impairment that we don't know about. Great. Somebody's worried about the falls. So we want to probe a little bit more about that and what were the circumstances for that.
I would like to verify her medications to ensure that she actually has the right medications.
Yeah, exactly. A little more specificity about all that, about what she's taking.
Medication reconciliation
to see if she needs all the medications she's on, or does she have polypharmacy and taking more than one medication for the same issue, health issue.
Yeah, perfect. So we want to just make sure that there's no misalignment between what we want her to be on and what she ought to be on, but then also trying to keep things minimal and simple for her. We're wondering if she has financial problems. Maybe that's a driver behind her missed appointments. That's a great point.
And as a Caribbean person, are the medications expired? Because Caribbean persons don't like to throw away medications no matter how long they have them.
That's a great point. So the idea of like maybe there's lower efficacy or whatever because she's using old medications, or maybe even using somebody else's. A couple of people are wondering about her support at home and home care and her IADLs, and then specifically how the breathlessness is affecting her. So really getting into kind of what her functional status is. So this is great. Thank you all. And that really does lead into, so the way that I have conceptualized the different layers of home care are like this. So the simplest one, or the middle one, is this basic care. And so really without this inner layer of basic care, you're not going to be able to stay at home and stay independent. And then we'll talk through our way as we go sort of to these outer circles. So basic care. So what are the tasks that need to happen every day? And then who is providing this care, right? And so you reference this. This is really the ADLs and the IADLs, right? So these are the things that you need to get done to get through the day. The most basic things, right? So that's toileting. What else? Eating, getting food on the table, grooming. And in order for you to be at home, and not in a facility, then you would need to be able to do these things for yourself, or you need to have somebody to be able to do them for you. And if you don't have that, then you will at some point not be able to live independently at home. And so, I said, who provides this care, right? So we know this is both paid and unpaid caregivers. In many situations, it's family members, or maybe you have some amount of paid caregivers, either privately paid or from insurance through Medicaid. But lots and lots of family members are chipping in to fill those gaps. And we know that this is really physically demanding, emotionally draining, very intimate, and I consider it skilled labor. Probably many of you have experiences from both your own patients, but also from personal lives, right? Family members and such, how much we depend on our caregivers. Here in New York, we know that the paid caregivers are overwhelmingly women of color. Here in New York, it's primarily Black and Hispanic, and then less Asian and white women. Low annual earnings. And then I always find it sort of astonishing that it was within the last 5 years that they qualified for minimum wage. So it's really been a population of the workforce, which is vastly underappreciated. And we actually, not only is that there's a moral imperative to treat these people a lot better, but also I think there is an increasing recognition that paid caregivers are the people that are sort of keeping our system afloat, right? They're keeping people at home and not necessarily overwhelming skilled nursing facilities and such. And then we have unpaid caregivers, and that could be a talk unto itself about the huge number of caregivers that are providing a tremendous amount of care. And then there are many downstream effects, including physical, mental, and financial, right? Lost wages, people giving up jobs or opportunities to be able to care for loved ones. And I think we probably all have examples too of people who are in this position for people who may not even be family, right? A neighbor. So people are really stepping up to care for people who need it. And of course, we're very fortunate here in New York City because we do have the most generous Medicaid home care that you could find anywhere in the United States, right? Nowhere else in the country will you be able to find a 24-hour paid Medicaid paid for aid. But of course, that's getting harder and harder to access. Just a quick note, I'm not sure if all of you are aware, but that there are two different kinds of attendants. So there are home health aides, and then there are home attendants. I certainly wasn't aware of this as a resident, sort of only learned about this as a fellow. But if you have Medicare only, no Medicaid, then you will really only qualify for short-term assistance. So this is the kind, like if you're in the hospital and then you get discharged from the hospital, you may be able to get an aid for the short term, and it will only last as long as there's also a nurse providing services. And this is all part of a bundle of services that happen after for sort of acute care needs. If you have Medicaid, or if you're able to pay privately for an aid, if you're fortunate enough to be able to do that, then you may have a home attendant. And this would be more chronic, and these would be people who are, have an aide that's with them for years and years. And this could be up to 24 hours a day here in New York. And it's important to know that if your aide or attendant is being paid for by insurance, they really can't provide medication. So we probably all have examples of aides who actually do this, but by the book, if they're on paper, they're really not supposed to be. They can't do tube feedings and they can't do wound care. So there still are things that may need to be addressed or done by, whether that's a friend or a neighbor, filling in for those services. In the interest of time, I'm just going to skip this, but just to say that I think this whole last year and a half has been an incredibly interesting time to think about home care, because it's just shown us how intimately our patients, our homebound patients in particular, how much they truly depend on all these caregivers, right? So if there was a caregiver who got sick, couldn't come into work, didn't want to come in because they had other if there were other obligations that they had, or they got sick, we had many patients who may not have been sick themselves, but ended up in the hospital simply for care needs, and they had no other options. So I think it's just a good reminder of how much, sort of how tied our patients are to the caregivers. I think it's also important to recognize that right beyond the basic care, this eating, toileting, and whether or not they're alone at night, there also are those bigger questions of care and finances, and that may not be immediately obvious, right? Sometimes that takes a little bit of probing and getting to understand, get to know a patient before you can really understand, are they making decisions for themselves? Do they have a friend? And I think it's, especially when you're thinking about somebody with cognitive impairment and dementia, that may be something that you as a provider need to start thinking about early, so that you can help them recognize, eventual dependence for some decision making, and who are the people that are best served to do that. Skip this. So for Ms. M, we don't really know anything about kind of who's supporting her at home. Turns out she has a son. He lives in the city, but he, doesn't accompany to her appointments, and she's always been a little bit private. So, our task is really to think about her support system. So, okay, if we're worried about cognitive impairment, maybe the son, we need to start drawing him in so that he better understands what's going on with her. And then we would really want to assess, like, is somebody at home helping her? Is she able to do the laundry? Is she doing the dishes appropriately? Does the son or do her neighbors have concerns about how she's coping at home? And do we need to start thinking about applying for Medicaid or having some way to be able to get a home attendant at home for her? And then working with our IDT, and particularly our social workers, on how we're going to fill those unmet needs. Okay, so we've kind of talked about this basic care. Like I said, if you don't have this, somebody to do this for you, or you can't do it for yourself, you're not at home anymore. So the next layer is this chronic medical care. And so this is what I do. So this is a picture of one of my colleagues, home-based primary care. And some of you may have done this or taken care of a few patients through fellowship. And really it is just sort of translating a clinic model of primary care into the home setting. So I work with visiting docs. Mount Sinai Visiting Doctors, we're the largest academic home-based primary care program in the country. There are a lot of different models. Some are affiliated with academic institutions, some are private practice, some are concierge. Some are like ours, which are exclusively home visits. So I see my patients every 2 to 3 months, more often if needed. There are some models that sort of are a hybrid of clinic and home visits. Some may be consultative, so they do kind of a one-time home assessment. Sometimes this is done maybe after a transition of care, so after a transition out of the hospital or after subacute rehab, to really sort of, or maybe for a high-risk population, right, high risk for readmission to the hospital, you might go out and do that home assessment. And then there are some that are sort of more acute care based. So this company Landmark, I'm not sure if any of you are familiar with them. They work with, some of you are, I see. They work with insurance companies to identify people who are considered higher risk, and they're there to supplement the services of a usual clinic provider. So they might be able to go out and do a home visit, check for a UTI, start them on antibiotics, and then they'd send a report to that PCP. I think there's always some challenges when it's coming from an insurance side and not from the health system side because of just issues of communication, right? They don't have full access to a patient's medical record system. And so then that provider may not even know that somebody's coming out to see them. And then one of these newer ones is something called Prospero. I'm not quite sure how it's pronounced. They started out doing home-based palliative care, and now they are expanding into home-based primary care as well. Many different models. Sometimes it's the MD that's the primary provider. Sometimes it's a nurse practitioner. Sometimes it looks a little bit more like a hospice model where there are RNs doing some more visits, and then a lot of it really depends on kind of what your local structure is going to look like. So, and all of these are ways to be able to provide sort of access points to a patient who can't really leave the home or finds it difficult to get out. We talked before about these CHAs, so the visiting nurse services, right? So this is a bundle of services that comes with a visiting nurse. You can also access all the different forms of physical therapy and occupational therapy, speech therapy. Most often we see these when their patients are discharged from the hospital. So probably those of you who are trainees have, discharged patients with a referral to visiting nurse service. And ideally they would get a discharge summary, the medication list, they'd be able to go out to the home and reconcile the meds. And sort of make sure that transition is smooth. And then again, ideally, that visiting nurse would also then have communication with the primary provider. So what can they do? Vitals, monitor symptoms. They can help titrate medications. I think for those of you who are clinic-based, sometimes you can order this from clinic for for somebody who meets the criteria of homebound status. For insulin titration or blood pressure meds. They do a lot of teaching and training, so for both patients and caregivers. And then you can get, PT, OT, and then speech therapy. Speech therapy is one that I actually use a lot for my patients with dementia when I'm concerned about aspiration. And really that's because they can do a tremendous amount of counseling with the different aids that are in the home. And so in a way that is more practical, I think, than when somebody will get a speech therapy evaluation in the hospital, but who are those recommendations given to is usually the primary team who doesn't take care of the patient at home, maybe a son or a daughter if they're sort of sitting there at bedside, but those aides that actually take care of the patient at home are never getting those recommendations, are really never getting directly to them. And so I think it's an opportunity for the speech therapist to really interface directly with the people who are caring for that person on a daily basis. And sort of similarly for PT and OT, and they're in the home there. So of course, obviously, right, they're making recommendations for a chair that fits in that actual shower. And this is New York, so people's apartments are very funny, right? They're very small, or they're funny, they're shaped funny. And so you never really know if you order a tub transfer bench, is that going to actually even fit in their bathroom? And if it doesn't, they're not going to use it. So. Okay, and then the other way that I sort of think about chronic medical care being able to be provided in the home is through home hospice, which obviously is for folks who have a limited prognosis of, we think, 6 months or less. But I sort of categorize it here because it's giving somebody sort of regular touch points with a provider. Right? Somebody who knows them, a visiting nurse who's going to come into their house minimum every 2 weeks and hopefully more, and giving them an opportunity to address sort of more chronic issues and not have to pick up the phone. And it's a much more proactive rather than reactive service. So back to Ms. M. So for her, what we might do is we might think about ordering a CHA from this visiting, from our visit today, and saying to the visiting nurse, look, we'd love you to do a med rec, counsel about your medications, your diet, her fall risk, maybe assess, are there rugs on the floor, what's the lighting like, home safety, and then we can get some PT and OT in for her as well. And we might consider referring to our home-based primary care service if there's one that exists in our area. And there is actually the AAHCM, which is the American Academy of Home Care Medicine, has a database on their website where you can actually search by location to look for home-based providers. You know, it's hard because you never really, it's just a long list, but you may be able to find somebody who's very local and then find out if colleagues or whatever have worked with that person. Okay, so we've kind of moved to this middle circle, and then we'll move out to the last one, which is acute medical care. So any questions so far?
Again, feel very comfortable to unmute or put something into the chat. Geriatricians are the gentlest of question answerers in medicine. Oh, everyone here.
Somebody had a question about the M11Q. So is that for home attendants? Yeah, so that is for, that's kind of certifying that somebody has an ongoing need for home care services, which is that chronic home attendant. It wouldn't be, it's not for the, yes, it would be for basically anybody who has Medicaid and has a long-term home aid.
So the M11Q is not relevant for the CHA.
Correct. That's my understanding. Yes, that for a CHA, you just have to do you would do a referral to a nursing agency, Visiting Nurse Service of New York, or what else? There are many, Constellation, et cetera, et cetera. There are a lot of different agencies. You would fill out a face-to-face just saying that you've seen the patient within the last, I think it doesn't even have to be within the last 30 days. I think it's 60 or 90, and that they qualify as homebound, and that's the only thing that you would need. And then those CHA services are going to be short-term, so might be 30 days, 60 days at most.
And I have a somewhat related question. This is Shirley Gerard, and that is how cost effective this is for the practice, because it's expensive, especially when you add in travel time to get to and from a place. So your providers aren't doing billable events. So how does the practice deal with that from a financial perspective?
Yeah, so that is a great question. It's a big question. I would say that this is really an ongoing problem. So like in a fee-for-service world, it's very challenging. I think the direction that things are moving in financially is to have more of is to form contracts with particular insurance companies, right? I think that so that you would take on, so for instance, we're taking on patients from Health First and we're taking on total risk for them. And same thing, we have a contract with Humana. And so if there are patients who are deemed sort of high risk and we think we're expert at taking care of those patients, then they would be sort of prioritized for enrollment in our program. And we're taking on total risk, meaning that if they get admitted to the hospital, if there are sort of more, if we don't do what we think we can do, which is keep patients at home, and sort of minimize cost and emergency room visits and all of that. If we don't do that, then we're sort of on the hook for it. On the flip side, if we do the thing that we think we're good at, which is all of that, keeping people at home and minimizing cost, and sort of matching care to what people value, then we share in those savings. And so I think there have been a lot of different ways that people are trying to work that out. And so actually, I mean, I think just to go back to this slide here, I think the reason that there have been so many different agencies, and this is just a small number of them, right? The reason that there are a lot of different companies that are interested in working with this is because it is in the interest of the hospital system, or in like the healthcare system at large, to be able to sort of minimize hospitalizations and all that, right? And try to reduce waste within the healthcare system. So I think that's not really a direct answer. I think on the like a small scale basis, yes, our visiting doctors program is very expensive, because you're right, because we don't pay for clinic space, but what we do, we are paying for all of us to go out and about. We obviously can't see the same volume of patients per day. But I think when they have looked at programs like this, they do tend to be able to keep costs down, right? A lot of it is just, many of our patients don't want to do as much testing, and, therefore, I don't know. So we're kind of, it matches better with what people want. I hope that helps a little bit. And I think the other way would be that you would think about a non-totally home-based program, right? So you might have one. So our geriatrics practice, for instance, has a small program within it that deals with patients who are considered high risk for readmissions. And so as part of that, they do sort of one-off targeted home visits when they think people need it, which might be somewhat of a more cost-effective way to deal with that.
And the way that's structured is it's set up so the hospital doesn't lose money. So the hospital makes the investment rather than, even if primary care delivers the service, or the hospital system. So it's in the hospital's best interest to keep that person out. Otherwise, they're penalized by Medicare, Medicaid. So, I mean, I raise the issue knowing how complex it is, and that we really are in desperate need of revision of our healthcare financing system.
I agree with that. Okay, well, so this might be interesting then to you then. So I think I just wanted to address kind of this acute medical care. So how is it that people are going to, right? If you have a crisis at home, how do we deal with it? And typically, right, in a typical model, there are two options, right? If somebody calls their doctor and says, I'm feeling short of breath, then in a typical primary care practice, you probably don't have much recourse except for to say, okay, well, then you need to call 911. Maybe right now, maybe there are more urgent care centers than there used to be. So you might be able to get somebody to an urgent care center for an semi-urgent evaluation, right? And this is if you assess somebody on the phone and you're like, well, you sound sort of short of breath, but you're not imminent. Like, I don't think you need to call 911 right this second, but you still might not have that many options. And I think, so one of the things that's been interesting is kind of seeing the rise of different kinds of models of care to be able to kind of provide more care across the spectrum. So one of the things that Sinai has been doing recently is something called community paramedicine. And this is a pilot that's been going, or it was a pilot that's been going on for, I don't know, probably about 5 years now. And have any of you heard of community paramedicine in any other contexts, or? Okay, at least one, maybe not a lot. And so community paramedicine is just a recognition that paramedics are highly trained, right? They're the most highly trained of the emergency medical personnel. And they're already out there in the community driving around with a lot of things on their van. So is there a way that we can harness them to be able to create more seamless care for our patients? It's used all around the world in different capacities. So in some places that are more rural, they provide wound care. They've been trained to do wound care. In some places, they have been used to do kind of a transitional care model for people who have heart failure. So they will go out after a heart failure patient is discharged. I think this was in Texas. Patient gets discharged from the hospital. The paramedics go, weigh them, report back to cardiologist or PCP. They can help titrate the diuretics, and they've been shown to decrease the readmission rate for these folks with heart failure. So there are just a lot of different ways that they can be used, which is, I think, is very, very interesting and very, like, there are a lot of, opens up a lot of possibilities. So here at Sinai, the way that they've been used is to really provide sort of an additional level of triage. So let's say we had that person who called in and said, I'm feeling short of breath, but you talk to them, they can talk in full sentences, but they have a history of COPD, so you're a little bit worried about them. So what you can do is you can say, look, I'm going to call for a community paramedics. You call Mount Sinai and you say, I'd like to request this service for my patient. They'll give you an ETA, so it's usually about 45 minutes. So then they'll go. And then we do an actual video visit with the patient. So ordinarily it's with an emergency room doctor. For our visiting docs patients, we actually do it ourselves. So I'll request the service, the paramedic shows up, turns on their video chat. I turn on mine. It's a specific app that we use, and I can actually see them for myself. The paramedic can get a full set of vitals and EKG if they need to. There's oxygen. They've got medications, so they could give Lasix. They could give a bolus if a person's hypotensive. They could give Zofran if somebody's nauseous and vomiting. And a lot of it enables you to sort of take another step towards talking with that person about their goals too, right? Incorporating their goals and values into this question of triage. So instead of having to say, well, look, you have to go to the emergency room because there's nothing I can do for you over the phone, you now have a way to be able to maybe administer something, maybe tide them over for an urgent visit the next day by a provider from your practice. And you just get so much more information, right? You have a full set of vitals now, and you can actually see what they look like. And if it's a patient of mine, then I can say, okay, actually you look like you're at your baseline. I feel comfortable letting you stay at home. And they, depending on their preference, they can do that or not. Somebody just asked how this gets initiated if it's the emergency room doc instead of visiting docs. And this would look very similar. I would still, let's say I would request it for my patient. And then instead of calling me to do that FaceTime and the triage, they would call that emergency room doc. And they've gotten really skilled at doing this telemedicine encounters and sort of talking with them about kind of what seems appropriate and then making a recommendation, and then they'll get back to the PCP. It's been hugely helpful. These numbers are really, they are out of date, but they've seen over 1,600 patients since inception. The majority of them do stay at home, and for our visiting docs practice, you can see that it is actually, it's a much higher percentage, probably because of that goals of care, and because we know our patients a little bit better, and because we can arrange for very, very close follow-up the next day. This is active in all 5 boroughs. And so that's just been this was hugely helpful during the pandemic as well, right? So there were so many of our patients who just would refuse to come into the ED even if they were reporting symptoms. So another model, which I don't know if you have a hospital at home program at your institution, but a lot of programs are sort of looking into this idea of being able to do an inpatient hospital admission, but at home. And so this would be, right, you're not your sickest patients, but it might be somebody who's got cellulitis that was refractory to PO antibiotics. And so you want IV antibiotics, but do they really need to be in the hospital? Probably not. You can have a nurse, they're getting daily visits from a nurse and an MD or nurse practitioner. They can get IV medications, they can get oxygen in place. There's a lot of things it should be the same level of care, and then 24/7 support by phone. And then there are some post-acute services so that, people are checking in with them by phone to make sure that that transition is smooth. And of course, a lot of this is about patient selection, right? Is it somebody who we think is maybe high risk for those hazards of hospitalization if they come into the hospital? And would just do better and be more active if they stayed at home? conversely, we have some patients who, an admission is maybe not the worst thing in the world because maybe it offers a bit of respite to their primary caregiver at home. So I think a lot of times you really have to have that full picture of like, what is it that you think that they could benefit from? But for a lot of people, this can make, hospitalization can be really traumatic for some of our geriatrics patients. And so this offers another option for our patients. And so this is exciting. And so it's been used, it's been piloted all around the country. This guy, Bruce Leff, has really been the pioneer in this field. And he's really like the sort of guru about hospital at home services. And they have found that there are lower costs and good satisfaction, shorter lengths of stay. And this is, just due to the fact that, right, if someone's in the hospital, you order more because they're there. So, they get labs every day, and maybe they get a lot of imaging, right? And not all of that is going to be the case at home necessarily, right? It's going to be just a little bit more targeted to what that patient actually needs. So for Ms. M, we see that we've got some options for evaluation now. So we might be able to round it out by saying, in addition to just talking on the phone, we can do a video visit, right? We all feel much more comfortable with video visits now than we did a year and a half ago. We might be able to offer an urgent visit. Or if she's feeling really short of breath, then we can offer that community paramedicine. And then, of course, there's the ER. And I think what I find exciting about this is just a sampling of some of these new models, but I think what is exciting about them is the idea that it feels like we're starting to think about treating our patients where they are, as opposed to making them fit into a model of care that already exists, right? Saying, well, here we are in the clinic, so you've got to come to us to be able to be seen. And so I think that's what I find really exciting about all these different models. So we've now sort of worked our way from basic care, and that's what really everyone needs to stay at home. And as you kind of go to these outer circles, these might be other services that you might be able to access in your different communities. And this is going to be very local to where you are. So if you're starting out as a primary care doctor in a new community, it might be really important to you to sort of learn about and ask about what kinds of resources there might be like this in your new setting. We don't have to do this. But really, I think home-based care, I'm really glad that so many of you have had an opportunity to go out on a home visit. I hopefully all of you will at some point. It is really fun. It offers this totally unique way to be able to see our patients and sort of get even just a small viewpoint into what their lives are like and the challenges and the assets that they have. It's shown me so much about how we really depend on those people who care for them at home. I think I see all these patients who I might ordinarily otherwise never have seen. And I think constantly, so I'm both geriatrics and palliative care trained. And I often think that doing visiting doctor service is sort of it's a really easy and so totally gratifying way to be able to provide goal concordant care. I feel like I'm constantly using both sets of skills, not that they're so separate, but being able to use both. And there are a lot of new models on the horizon, so it's really exciting. Anyway, thanks for listening. Does anybody have any questions?